who work with me in clinic know that a couple years ago, maybe 4 years ago, there was this big paper in the New England Journal showing that one of the most important things that would impact the 10-year mortality for patients would actually be bariatric surgery, more so than any of the other stuff that they compared it to. And they looked at metformin, they looked at intensive weight loss programs and other comparisons. And bariatric surgery was the most likely to extend your life by 10 years. And so, ever since then, I'm a hound on the residents, always asking about referral to bariatric surgery program. So this is a topic that I find super interesting, and I can't wait to hear from Dr. Abbas. Dr. Abbas, you can take it away, but your slides went away. They were up and now they're gone.
Thank you for being there. Thank you for the nice introduction. Let me try to share my screen now, and let's see if we can have the slides. Let's try again. I think it's doing the wrong thing. Let me try to share that. All right, now can you see my slides? If you can just answer me or by chat, that'll be great.
Yes.
You're good.
Perfect. All right, so thank you again for attending. Today I'm going to be discussing the bariatric endoscopic therapies and obesity management, and also a little bit of pathophysiology about obesity and why we have this epidemic, and how can we help to improve the outcomes for patients with higher BMIs. No conflict of interest here. The objective that I have is, or basically are 4 points. I'm gonna review obesity as a chronic disease and also review the current available options in terms of management, and review the endoscopic therapies that are currently available in the market, and also review the ones that are coming down the road in the next 1 to 2 years. Obesity epidemic, we all know about it. This map is getting darker every year, and now 1/3 of the US population have BMI above 30, which is a very staggering number. Yet, as Dr. Oshner said, the bariatric surgery is very effective, but only 1% of those who are eligible, based on the insurance and guidelines definitions, who are eligible for bariatric surgery are actually getting them. 1%. So you have a lot room for improvement. The barriers are a lot, very understandable, very reasonable. There is the different comorbidities that prevent surgical intervention, adverse events, patient preference. Some people will not approve undergoing invasive surgery, and the cost. In terms of pathophysiology, I mean, we live in a lifestyle nowadays that promote excessive energy storage. Energy intake is always more than the energy expenditure. There's multiple genetic and physiological and environmental factors affecting that equation, and especially in our current lifestyle, the increasing per capita food supply and consumption, and they're rich in calories, decreasing time spent in occupation with physical activity. Most of the occupations are sedentary nowadays, and growing use of medications. There's a lot of medication that can promote weight gain, and basically inadequate sleep epidemic. That's another topic by itself, but there's a lot of sleep, a poor quality of sleep, and this is a vicious cycle. Poor sleep quality can cause obesity. Obesity can cause poor sleep quality. And then overall, the medical innovation that have reduced mortality for infectious diseases and prolonged lifespan set the foundation for the conjoined epidemic of chronic disease and obesity. So this is just the natural process of the modern lifestyle and modern medicine. In terms of genetics, there are a lot of genetic markers and other genetic mutations that have been recognized that has been associated with obesity. Most of them associated with childhood obesity. It's beyond the spectrum of this presentation, but I just wanted to present this list of multiple markers that has been associated with childhood obesity and subsequent adulthood obesity. And every few years, new markers are being discovered. In terms of medications, I mean, this list is encompassing pretty much about 70 to 80% of the medication that we use in our medicine practice: neuroleptics, antidepressants, SSRI, beta blockers, diuretics, and and then even contraception. Some contraception pills has been linked to increase calorie storage and weight gain, although the research is equivocal. Basically, the more medical problems, the more medication use, the more weight gain. This can happen with the patients. And then in terms of the neurohormonal signaling, the classic thought process of leptin versus ghrelin, this is way too simplistic, and it is currently we know it is much more complex than this signaling. The classic teaching is ghrelin is produced by the stomach, and it's a signaling hunger to the brain, and leptin is produced by the adipose tissue, and it's signaling satiety, and there's a balance between them. Now we know that there are more than 50 gut hormones and peptides, and they are all active in controlling the appetite and glucose homeostasis, calories storage, or adipose tissue formation. The most prominent ones that we have targets to medication to work with is GLP, in addition to, as we know, insulin. The rest are still under, basically investigation, and we're not sure exactly how we recruit them to help us in terms of the obesity management, but it is work in process. These hormones all signal to the brain satiety, most of them negative feedback, except for ghrelin, and they also interact between each others. There is the pancreas, the small bowel, and the large bowel, and the stomach. All of them are hormonally active organs. We used to think about the GI system as absorption and digestion, but there is a lot more to it in terms of the neurohormonal signaling and the metabolic syndrome and controlling the metabolism of the body as a whole. Now, why adipose tissue is bad for the health? The adipose tissue is actually a pro-inflammatory tissue. It increases the secretion of adipokines, and these are pro-inflammatory cytokines, and they have a role in impairing insulin signaling and also increasing insulin resistance and subsequently diabetes formation. Adipose tissue release lipids, and they will create dyslipidemia, and also they will create lipotoxicity, which is the deriving factor of NASH, non-alcoholic fatty liver disease, and subsequent fibrosis and cirrhosis, in addition to coronary artery disease. In addition to that, they increase the sympathetic nervous system drive and increase the renin-angiotensin system, promote hypertension and pulmonary hypertension. In addition to the mechanical effect of increased body mass on the joints, on the intra-abdominal pressure that promotes reflux and GERD and esophageal adenocarcinoma. So there's multiple venues for adipose tissue to produce clinical comorbidities. That's why adiposity or high BMI or obesity is a chronic condition by itself. Due to the fact that the pathophysiology is ongoing to promote that condition, in addition to the fact that this tissue is pro-inflammatory, and it is something that has to be considered as chronic disease. Just like hypertension and diabetes, you should address that in your visits. In addition to all of that, there is a huge mental and psychological burden associated with it, and social stigmatization. All of that will increase cortisol level and will furthermore increase the chronic medical problems. So basically what we discussed is the pathophysiology, the consequence of increased adipose tissue and the body. Now we're going to talk about the available management, the ones that you as an internist, and also we talk about the patients. Everyone has to kind of counsel the patients about the lifestyle modifications. And diet is a very effective tool in inducing weight loss. It is not a good tool for maintaining weight loss. And we'll come in a second to discuss why is that. But most of diets are focusing on calorie reduction. I mean, I'll take it back. All diets are focusing on calorie reduction by about 500 calorie per day. Some of them have low fat plans. Some of them have low carb plan like Atkins or keto, and some of them are balanced. So they reduce the all of the components of the nutrition at the same level. Regardless of the diet, they all seem to be effective, around 6%. Some of them are around 10%, basically 6 to 8 to 10% total body weight loss. And it's very highly variable among patients. And the low carb diet appears to be the quickest in terms of inducing weight loss, but the hardest in terms of maintaining. And in general, all diets are hard to maintain weight loss because of this factor. It is the leptin level. When you have fat tissue, that will produce leptin. And when there is reduction in the fat tissue with the diet, with the loss of that weight, the level of leptin will go down. And that will signal to the brain that you are in a starvation mode. And that will basically shut down your metabolism and suppresses energy expenditure and suppresses thyroid and reproductive hormone and also reduce the immunity. And that will give an impulse to overfeeding when possible when you have leptin deficiency. So a classic example about the leptin profound effect is lipodystrophy. It's a condition where basically a person lack any ability to produce fat cells, and they will have immunological and reproductive deficiencies, and these can be reversed by providing leptin, because that will signal to the brain that they are able to attain these functions and they are not in starvation. So basically, this is why diets are prone to fail. This is an evolutionary mechanism. If you are in a cave and you're starved for a couple of weeks, everything will be recruited to maintain your life, and that's why most people who like for example, The Biggest Loser, they all regain weight. Most of them regain weight, and it will be like a pendulum effect. They go to a diet, they lose weight, they are unable to maintain, and they regain weight, and so forth. Eventually, they end up in our clinic for a discussion of further intervention. So, diet is good induction. Exercise is a good maintenance for weight loss in terms of lifestyle modification. And to lose weight on exercise, you need to exercise a lot. If you did not take a diet in combination with the exercise, you will pretty much need to, let's say the class example, when you ask patients, are you exercising? Like, yeah, I walk my dog. So if you want to induce 1 pound weight loss over a week time by walking a dog or just walking on the street and when the weather allows, the patient has to walk 5 miles per day for 7 days to be able to generate a calorie deficit of 500, which will be in turn translated to 1 pound per week. So this is not practical. So that's why walking, exercise by itself without diet will not induce weight loss, but is a good strategy to maintain weight loss. And also the resistance exercise, like building muscles and especially lower body, can produce more calorie deficit and also can raise the metabolism and counter that signal of starvation due to leptin deficiency. So the best counseling method for the patients will be diet for reduction, exercise, resistance exercise for weight loss, for maintenance. In terms of the FDA approved medications, we have several of them now, about 5 until recently. Belvic was withdrawn from the market due to cancer risk, but the top 4 focusing on central appetite suppression, and they have a lot of anticholinergic and psychological side effects. And the bottom is focusing on GLP, which is the relaglutide and semaglutide, Saxenda and Wegovy. They are exactly the same medications like Victoza and Ozempic for diabetes, but on a higher dose. And basically, the FDA labeling has to have a different brand. So both of them are very, I will say, the highest efficacy that we observed in terms of medication, were with Saxenda and Wegovy, which is about 8% total body weight loss. Both of them reduce the gastric emptying and promote satiety, but they can be associated with pancreatitis, and they are not. They are contraindicated in people who have multiple endocrine neoplasia or family history of pancreatic cancer, or any, honestly, any cysts in the pancreas might disqualify these patients from Saxenda and Wegovy. So overall, these are good tools as an adjunct for lifestyle modification or surgery or endoscopy. They are unable to have a sustained results or a good results by themselves. Now, moving to surgery as an option, it's been around for a long time, and we have multiple surgeries. Now, I'll say the four successful surgeries that survived the longest are what's shown here. The lap band is out of the picture right now because of the complications. So now we have the bypass and the sleeve gastrectomy and the duodenal switch. In the early 2000s, the bypass was the most commonly performed surgery, and nowadays it's the sleeve gastrectomy is the most commonly performed surgery. The shift is unclear. Probably it's much more easy to do sleeve gastrectomy, has been associated with less complications, but the results has been still not as good as the bypass. So we still recommend bypass for people who are super obese, above BMI of more than 50, and so forth. But again, regardless of the option, which a decision will be done by discussing that with the surgeon and also with the patient in a multidisciplinary fashion, the only less than 1% of people who are eligible for that are actually getting it. So now, I love this slide because it kind of show that how are we evolving in terms of our understanding of what is happening with these surgeries. The classic teaching is malabsorptive restrictive. We talk about bypass as malabsorptive. We talk about the sleeve gastrectomy as restrictive. But the fact matter is actually the neurohormonal effect of these surgeries are what is basically what is inducing the weight loss and the suppression of the appetite. It's all around delivering calories and energy early to the distal small bowel to potentiate the signaling of GLP-1 and GLP-2. And we used to think about the ghrelin when you do a sleeve gastrectomy, or we use bypass, you're going to suppress the ghrelin, and the research has not shown to have any predictive effect. So it is all about the neurohormonal. There is some restrictive component, but the most I would say the most effective way of inducing weight loss by appetite suppression is through the neurohormonal effect of these surgeries, not due to malabsorptions. Otherwise, everyone will get chronic diarrhea and steatorrhea after these surgeries, and rarely we get that after bypass if the limb is too long. So now, in terms of the continuum of obesity care, so as we said early, the obesity is a chronic disease. So any chronic disease, you have to have multiple options throughout the years to kind of tackle it and bring it under control. It is not like one and done. You get bariatric surgery and you're done. Your metabolism will be prone to weight regain. Will be prone to storage of calories. So there is a continuum of care, starting from the lowest risk, which is the lifestyle modification, medication, and then ending with surgery. And in between, until recently, we did not have nothing. I would say until the last 10 to 15 years, we didn't have any serious options that we can consider as a bridge between lifestyle modification and surgery, and until the evolution of bariatric endoscopy. Now, the good analogy is coronary artery disease. You have CABG on one side, and you have beta blocker and other medications. And in between, there's stents. There's cardiac stents that can help people with their coronary artery disease. Same analogy with obesity. All right, sorry. So this is a little bit technical, but to evaluate the efficacy of any intervention, you have to look at two parameters, which are the total body weight loss percentage, which is the delta before and after the intervention, and also the excess weight loss, which is the delta from the ideal body weight. So these two parameters have been used to evaluate the efficacy of the endoscopic therapies that we have. And who decides is this endoscopic therapy is effective or not? In 2011, the American Society of Gastrointestinal Endoscopy, ASG, and the American Society for Metabolic and Bariatric Surgery, ASMBS, sat together and defined the what they called the preservation and incorporation of valuable endoscopic innovations, PIVI thresholds, which basically saying that if we are going to recognize or endorse an intervention for obesity as a society of bariatric surgeons and bariatricians, we will have to achieve this level of efficacy. So in terms of the endoscopic therapies, they set the 25% excess weight loss as a threshold at 12 months. And they set 15% excess weight loss above the control group. In addition to that, they set 5% total body weight loss for the revision and also for the overall complication to be less than 5%. If any therapy under development achieved these thresholds, they will be willing to endorse it and accept it. An endorsement from societies will make it mainstream. It will make it, the CPT code will follow and the insurance coverage will follow. So since then, it has been 10 years since this paper. Multiple devices has been evolved, and some of them obviously before that paper, but have been getting a lot of push afterward. So this diagram illustrates the primary interventions that we have under development or currently available. There's balloons, there's the transpyloric shuttle, which is intermittent obstruction of the pylorus to delay gastric emptying. There is the endoscopic gastroplasty, there is pose procedure, there is the Aspiration assist, which is a PEG tube that evacuate the contents of the stomach. And there's a small bowel interventions, there's endobarriers that are currently withdrawn from the market and being redeveloped. There is the magnets anastomosis, and there is the duodenal mucosal resurfacing. So it is very active field, very evolving field, and there are a lot more coming. Balloons has been in the market or has been available since the 80s, withdrawn and then came back in Europe and then subsequently came back to the United States after 2015. There is water-filled, there's all kind of shapes, there's swallowed, there's air-filled. Regardless, they are space-occupying objects. They delay the gastric emptying, promote weight loss through that mechanism. At 12 months, it's about 25% excess weight loss and about 11% total body weight loss. Thousands of people had it worldwide, and there are a lot of meta-analysis about that. The issues with them is they are good for induction, but they are not good for maintenance. So if you remove the balloon, which is approved for 6 months only, there is a high risk of weight regain, very logically, due to the removal of the factor that promotes weight loss at the beginning. So the patient has to understand that this is a weight loss induction, and they have to continue the rest through lifestyle modification and exercise and medication. In terms of side effects, 1/3 of people who gets the balloon will get accommodation phase problems, which is nausea, vomiting, abdominal pain. There's 7% early removal risk due to intolerance. Serious side effects are very rare, less than 1%, and it's mostly related to prior surgical intervention or alteration of the bowel, and that's why it's contraindicated to place a balloon in a surgically altered stomach. AGA endorsed the balloon placement in 2021 for patients who are failing lifestyle modification between BMI of 30 and 40. So this is the first society to endorse it, and hopefully the ASMBS will recognize it soon. Now, moving shifts to the endoscopic sleeve gastroplasty. It has been a dream of a gastroenterologist since the beginning. to be able to alter the gastric cavity. And there are a lot of devices that has been tried and failed. And this is one of the earliest ones, I believe, in 2008. And it was a collaboration between Cleveland Clinic and Brigham Women's Hospital and Boston. And that device could not sustain good results due to the fact that these sutures are mucosal sutures. They're not full thickness. The paradigm has shifted when this device came to the market, and it allowed full thickness suturing from inside using a flexible endoscopy. This device called Apollo over stitch, and the first case of endoscopic sleeve gastroplasty was done in 2012, exactly 10 years ago. Since the original case, multiple modification has been introduced, and the most commonly accepted pattern now for suturing is U-shaped pattern, starting from the distal aspect next to the pylorus and all the way up next to the cardia, and starting from the anterior greater curvature to the posterior wall and back up. The MERIT trial, which is a multi-center trial that has been designed for FDA approval for this device, this surgery, this procedure as anti-obesity therapy, is finished right now and is expected to be fully published in 2022, which is this year. And this procedure is one of the procedures that we did in TGH. And you start by marking the stomach from inside to decide this is the area that we're going to collapse. And we spare the fundus for possible gastric bypass in the future if they needed to convert to a bypass. So this is the corkscrew is basically digging into the wall and then pull it, creating a fold. And then the needle moves from the top of the screen to the bottom of the screen. And then we tighten this, we continue to take bites and sutures one after the other until we make a U shape and tighten it. This is after we finished about 4 to 5 sutures, and you can see the stomach cavity is completely collapsed, and it is sutured just like an accordion. It's wrinkled. Nothing is getting cut. It's basically restricted and smaller in size. This is the MERIT trial, as I mentioned, is hopefully going to get the FDA approval and labeling for this device and this procedure, and has been. They announced that they met their efficacy and safety outcomes, and this is how it looks. Right before, after, and 3 months after. You can see that there is sustained efficacy of reduction of the stomach wall, stomach cavity, in addition to the decrease the compliance in the stomach. Multiple studies, excuse me, has been published about that. And this meta-analysis compared the endoscopic sleeve with the surgical sleeve gastrectomy. And we have to point out that about the patient population of this meta-analysis is different. For the endoscopic sleeve, is between 30 and 40. For the surgical sleeve, is mostly between 40 and 50. About 2,000 of each arm. In terms of efficacy, the endoscopic sleeve resulted in 17% total body weight loss at 12 months, whereas the surgical sleeve resulted in 30% total body weight loss. But if you look at the excess weight loss, it's about 60% for both of them, and the final BMI is about 30 for both of them. So that tells us that for a patient population between 30 and 40, the endoscopic sleeve was able to perform as good as the surgical sleeve and bring the excess weight by 60%, and with the resulting BMI 30%. So it is less effective than the surgical sleeve. But for people who are not eligible or unable or unwilling, especially for this range between 30 and 40, the endoscopic sleeve can offer a very effective option for them. Anything above 40, they are going to be better served by a surgical intervention. In terms of the side effect, understandably, the endoscopic route has been much more safer and less complication in terms of the GERD. As we know, the sleeve gastrectomy can trigger new onset GERD in up to 1/3 of the patients, and the endoscopic sleeve is very low risk. In terms of the long-term efficacy, it's about we have data for 5 years now from Cornell, and it showed persistent efficacy about 15% total body weight loss. And again, the first procedure of this kind was performed in 2012, so it's still very early, but it is very promising results up to 5 years that we know so far. So the bottom line, who should we offer ESG? For people who do not meet the surgical criteria, especially between the 30 and 40 BMI, and also for people who are not surgical candidate for any reasons, chronic steroids, hostile abdomen, frozen abdomen, multiple prior surgeries. This can be the only option that are available. And also as a bridge for surgery, there has been studies coming out of Germany. They use it in the super morbidly obese, BMI above 60. They use endoscopic sleeve, they reduce weight loss, maybe to the BMI 50, and then they end up with a bypass to reduce the comorbidities or the morbidity of the bypass on people who are very poor candidate. So as a bridge, and also for ineligible, but ideally those between 30 and 40 BMI will be benefiting the most. Excuse me. Now this device is has been used to do endoscopic sleeve gastroplasty. This is called Pose 2. It's a platform that has a flexible tube that can carry a scope, a grasper, a helix, and then this tissue grasper can deploy an anchor, and that anchor can reduce, create a fold in the stomach of about 7 centimeters. And this device originally was designed to perform NOTS, which is natural orifice surgeries through the stomach. And some people actually did cholecystectomy using this platform. But nowadays, we've been using it successfully to do the endoscopic sleeve gastroplasty, to remodel and reduce the size of the stomach through the mouth in a much more efficient way as compared to the other device that I showed you. So the trials are still ongoing for this device, and we will know if this is more effective than the Apollo, or they have the same efficacy. So it's another option that's coming down the road. Aspiration therapy, this slide is mostly for historic data because last month, after the slides were prepared, the company that is making the aspiration therapy went out of business, and they cited the COVID impact on their profitability. So now this device is not available, but the concept is very interesting. It's basically just a PEG tube that has the capacity to evacuate and do lavage and wash the stomach to evacuate the contents. And there has been an FDA approval, a trial about that, and it showed that it basically can reduce sex weight loss about 30%. So it's very effective, but requires a lot of compliance from the patient, and also has a lot of complications related to the PEG tube, fistula, peritonitis, pain, and there has been a lot of concerns about the encouraging the purging behaviors. But in this trial, they did psychological analysis and evaluation of these patients, and they did not see any evidence of encouragement of such behavior, and the efficacy has been documented in multiple studies. All right, so these three devices that I showed, which is the balloon, the endoscopic sleeve gastroplasty, and the Aspire Assist, has been available on the market, and we've been doing these cases for the last, I would say, at least 3-4 years, and has been available, and most recently at USF for the last couple of years. Now, the other devices that I showed earlier are still under development, and I will touch base on some of them at the end of my presentation. The other concept of the obesity management is basically revisional, or people who already had surgery and then regained weight. You know, I always say that when I was an internist, when I was a resident in medicine, I had no idea that people who had bypass or sleeve gastrectomy and they continued to have a high BMI or regain their weight, had no idea that they can had a revision intervention. I send them to the bariatric surgeon. The surgeon will say there's nothing wrong with them. They come back to us. But most of the situation is the after the bariatric surgery, the revisional intervention can be very complicated and has to be specialized. It has to be done in a very specialized center. So most of the practices in the community shy away from doing revisions. Here at USF, we do a lot of surgical revision. We do a lot of endoscopic revision, which has been evolving as a very effective tool to salvage these patients and prevent them from going back to a very high BMI. And as you can see in this study, almost everyone after bariatric surgery, after 5 to 10 years of having bariatric surgery, will regain some of the weight that they lost, up to 1/3. So, and the comorbidities will come back. So you have to do something to help them. The endoscopic intervention are two, basically. We can re-sleeve the endoscopic the sleeve gastrectomy by reducing its size with endoscopic suturing, just like the technique of the endoscopic gastroplasty. And for the bypass, we can restrict the outlet and also the pouch by endoscopic suturing. It's called TOR procedure, transoral outlet reduction. And I'm just going to skip this. For the TOR, we usually APC, which is ablate the mucosa to reduce ulcer formation and scarring. And then we start suturing from around the outlet in a per-string fashion. And then eventually, after we finish rotating the entire apparatus around the entire circumference, and we will, here I'm just taking a few more bites, and then I will put a balloon, which is a bougie. This is the outlet before we tighten it and cinch it. This is a balloon just to size it, make sure that it's not going to obliterate. And this is the results after the outlet reduction. And you can see before and after there's remarkable difference in terms of the outlet. This will induce weight loss in people after bypass. And this is how it looks after 3 months. We rarely scope them, but if in case we scope them for any reason, this is how it appears. The upper panels are from USF, the lower panel are from Hopkins. They have been very successful in inducing weight loss. In this patient, she lost about 40 pounds in 3 months. And these are the data coming from Brigham and Women's Hospital from Boston. It showed that this procedure induced about 10% total body weight loss up to 5 years of follow-up at this moment that we have. So it is a very good option, and this is the endoscopic sleeve gastroplasty as a revisional option also for the sleeve gastrectomy. After the soft tissue distension can increase the capacity, we can implement the same mechanism and try to reduce the size. And in terms of the efficacy, there are several studies have been evolving about this intervention, and it showed very promising 15 to 17% total body weight loss at the end of the first year, with almost 0% moderate to severe complications. So now we covered the revisions. There are two procedures: the transoral outlet reduction for the bypass, the endoscopic sleeve for the sleeve gastrectomy. These are the revisionals. The primaries has been 3 of them that I covered. And now we're going to move to the future interventions. And these future interventions are trying to focus on the small bowel. All of these are basically restrictive interventions related to the stomach, related to the pouch. Now the field is moving to the small bowel, trying to recruit this neurohormonal efficacy. And and the concept is revolving around the GIP and the GLP. The GIP is it's called glucose-dependent insulinotropic polypeptide. It's a peptide that is produced by the proximal small bowel in response to the calorie load that is coming from the stomach. It has been found that in diabetic patients, they have impairment in this peptide, and they get something called reciprocal or basically postprandial elevation of circulating glucagon, secondary to reduced to postprandial suppression of glucagon by insulin. So normally, when you get a PO intake, when you get calories into the proximal bowel, the GIP goes up, promote insulin secretions. But in these people with diabetes too, they don't get that response. So they get an unopposed glucagon surge, and that will further worsen the situation and post PO intake hypoglycemia. And the other side, the GLP, which is the peptide that is produced by the distal small bowel in the ileum, kind of opposite to that effect, basically signal satiety, slow gastric emptying, and promote reduction in the circulating glucose. So if we are able to recruit these two hormones, we will be able to improve the weight and the glucose homeostasis. And the current evolution of the anastomosis to try to divert some of the calorie load from the proximal small bowel to the distal small bowel without surgery led to the development of the incisionless anastomosis system. And at the initial phase, this is also coming from Brigham and Women's Hospital, and this is a self-assembled magnet that can be pushed through a flexible endoscopy. And if you have two endoscopies, one in the duodenum, one in the ileum, and you're able to couple these two magnets, you'll be able to induce pressure necrosis. It's called compression anastomosis, and connect these two lumens without the need for surgery. And this is how it appears in pig models. And this is one of their experiments. This is how it looks on the actual procedure. They use X-ray to try to couple the magnets together, and just gonna. It's really cool to watch. That when they snap together, and then they use laparoscopy to confirm the coupling and make sure that there's no interpositioning of any other tissue at the same time. But the coupling has happened completely endoscopically. So and this is how it looks from outside, from the laparoscopic image. And this is 2 months after. You can see that there is an anastomosis, and the barium swallow or barium study has been confirmed that there's no leakage. So they basically sacrificed that pig, and they tested that the robustness of this anastomosis. This is very remarkable. Like you're talking about connecting two lumens without surgery, without stables, without suturing, through endoscopy. So this is a very significant breakthrough. So they got the FDA approval and as a breakthrough device, and they're right now basically moving towards the final trial. But they did a lot of testing to confirm the robustness of this device. And this device actually using what they call the Earth magnet, which is the neodymium anastomosis. If I'm pronouncing it rightly, I have no idea how to pronounce it. But it's the same magnet that they use for LINX procedure. If any of you guys familiar with the LINX procedure, it is a bead, a magnet that is placed at the end of the esophagus to reinforce the anastomosis and prevent reflux. The same magnet can be used to manufacture this compression anastomotic device, and they call it now SNAP procedure. And this is the study that has been published in obesity surgery last year, 2021, from the same group from Brigham and Women. And they modified their way of delivering the device. They basically used the laparoscopy to create a tiny incision and then deliver the ileal magnet through the laparoscopic approach, and the duodenal magnet through the endoscopic approach. And then they couple them through a combined approach, endoscopic and laparoscopic, and then this is the results. I think they had let's see, they have 8 patients. These are human trials, all of them with diabetes. Their diabetes is poorly controlled between 7.5 to 9.5. And this diabetes, this A1C got reduced to below 7 in about 75% of patients at 12 months after this simple 20-minute intervention. And in addition to some weight loss, but the diabetes reduction, the A1C, the improvement of the control is not correlated with the weight loss. It is purely related to the GIP, GLP effect of diverting some of the calorie load to the distal bowel early in the process. And that's why they proposed this SNAP procedure as an adjunct to diabetes management. And it is similar to the SADI or the pancreatic biliary diversion, which is much more complicated surgeries. The SNAP, the magnetic compression, offers a much easier, technically, and much safer alternative for these patients. Now, the second breakthrough that we have in the small bowel is the duodenal mucosal resurfacing. The same concept with ablation for Barrett esophagus. When we kill the Barrett mucosa, the body will regenerate healthier mucosa, and that is called eradication of Barrett. If we apply that concept of ablation to the duodenum to try to rejuvenate the enterocyte that produce GIP, this might have some insulinotropic signaling effect to help with diabetes. And this device is it's a very nicely designed. It is pushed over the wire to the duodenum, and then with the scope to the side of it, and there is a balloon with a needle that inject and provide cushion underneath the mucosa. So the balloon itself start getting heated and ablate the mucosa. And this, the early trials has been done in 2016, and it showed that for people who had less than 6 centimeter ablation, which is called short segment ablation of the duodenum, they had reduction in about of their A1C by 1.2%. And for people who had longer ablation segment, more than 9 centimeter, they have 2.5% reduction of their A1C. And this is again irrelevant to their weight loss. They lost a little bit of weight. So it's not meant to be a weight loss. It's meant to be a metabolic the diabetes management efficacy. And this is a meta-analysis of the trials. And currently there is an FDA approval trial that is undergoing. But the trials and the studies that has been done, it showed on average 1 to 2% improvement in A1C after one session of ablation of the duodenum. So what is 1 to 2% is a big deal in diabetes. You can see the hypoglycemic agents, all of them that are currently approved have efficacy between 1 to 2% of A1C reduction. Metformin is 0.9%. So having duodenal mucosal resurfacing as a adjuvant therapy for diabetes, one session per year, maybe 2 sessions per year, and someone who was on multiple medications is something that really can change the landscape of metabolic disease and endocrine management of diabetes. So, as a conclusion, obesity is a chronic medical disease and it has to be treated as such. It cannot be treated as one and done or an issue with the will of the patients unable to lose weight on their own. It's just not possible. Once it passes certain BMI, you have to treat it as a chronic disease. And it has to be dealt with as a long-term multidisciplinary approach with sequential interventions, starting with lifestyle, moving to endoscopy, moving to surgery, back to lifestyle. So there is a lot of interventions at each phase. And bariatric endoscopy is rapidly evolving to fill the gap in therapy. And to kind of summarize the efficacy, we have lifestyle and diet, about 6 to 8%. We have medications, 8 to 10%. We have endoscopic. Most of our endoscopic therapies, or all our endoscopic therapies, are between 10 to 20% total body weight loss. And the surgical interventions are the most effective, 25 to 50% total body weight loss. And then the metabolic endoscopic interventions are very promising as adjuvant therapies for diabetes and also for obesity. Thank you very much.
Any questions?
Could you, this is Barbara Hansen, could you possibly talk a little bit more or more slowly about the reversibility of these when, for example, sufficient calories aren't being taken or they get problems, or, you know, I know there are a lot of people who are not real happy about them. So what do you do and how do you do it, and which of these are not reversible?
All right, thank you very much for the question. Very important question, and I'm sorry I was a little bit fast because I have a lot of slides and topic to cover in a very brief time. So in terms of reversibility, the endoscopic interventions, the balloon is reversible. The endoscopic sleeve gastroplasty is reversible, I will say in the first couple of months. Once it passes that, there will be mucosal bridging and serosal bridging, and the reversibility will be very hard, if not impossible. In terms of the, do you ask specifically about the endoscopic or surgical options too?
Both.
Both. The surgical reversal is a drastic event. If someone who ended up with bariatric surgery and then needed to be reversed, that is due to a major malnutrition, a major problem with digestion or with tolerance, and they are reversible, but they end up like they can reconnect for bypass. They can reconnect the excluded stomach with the pouch and reroute the bowel. But these patients are going to end up with a lot of adhesions, a lot of pain. They will improve their nutrition, but they're not going to be as as normal in terms of the GI function. So they are reversible, but it is difficult. It's a complex surgery too. It's much more complex than the actual bariatric surgery.
And what's the minimum BMI that you consider appropriate for a candidate? Is it 30 or is it higher than that?
Well, yeah, 30 for endoscopic interventions, 27 and above if they have comorbidities, 30 and above regardless is considered appropriate for endoscopic intervention. For the surgical, as we know, 35 with comorbidities, 40 without.
Thank you.
Thanks.
Dr. Davis?
Hi, I just want to thank you for your presentation. It's very informative. I have a lot of patients. I'm infectious disease and I treat them in our HIV clinic, but we do a lot of their primary care. So if we were trying to help these patients with starting out with medications, how long of a trial do you give before you would refer them to endoscopic for endoscopic evaluation?
It is, I will say, variable. If you have someone who with a lower BMI and very motivated, you can try in your own clinic with lifestyle modification and medication. I would say if they don't have any good results by 6 months, in terms of structured, every 4 to 6 weeks, you're going to have a contact point with them, because that's what we do at the medical bariatric clinic we have in the bariatric center. They have a program, and every 4 to 6 weeks there will be a touch point with the nutritionist or with the medical bariatrician, Dr. Wiles, and if they are not making progress, they will escalate it to the endoscopic or the surgical consideration. So if you have that capacity in your clinic, I will say no more than 6 months.
Thank you.
You're welcome.
All right, looks like there's no more questions. Thank you, Dr. Abbas, for your presentation today.
Sure. No
I will
problem. Thank
have
you
the
very much.
recording for this up this afternoon.
Thank you. Have a good day, everyone.